Welcome to the Centenary Free Paper Series this evening, which is a breast and endocrine themed session. So we have two chairs for the session. So I'll introduce myself first. I'm Mark Sibring. I'm a breast surgeon from University Hospitals of Derby and Burton.
Hi, I'm Michael. I'm a general surgery registrar in the Whittington Hospital in London.
Okay, Ghazala? Have I lost my co-chair? Okay, I'm sure we'll get her back. Okay, so Ghazala, are you there?
Yes, can you hear me?
Now we can, yeah. Please introduce yourself, go on.
Yeah, I'm Ghazala. I'm one of the associate specialists in breast surgery and I work at Milton Keynes Hospital. Very
good. So the evening is split into two sections. We firstly have 6 short papers. Then we have the talking posters. And I'll remind you again at the end, but I'd also encourage you all to look at all of the other e-posters that are posted on the ASGBI website. We'll get the most out of the evening if everybody participates. So please, there's the question, answer and chat section. So please submit questions as we go. And Ghazala and I will do our best to incorporate those after every talk. So for the short paper section, we have 3 minutes per paper and then a couple of minutes for discussion. So I'll get Ghazala to introduce the first speaker.
So the first speaker is Emma Stewart. She is going to talk to us about the impact of radiotherapy on patient-reported outcomes of implant-based reconstruction from the results of a prospective multi-center cohort study. Emma, please go ahead.
Hi everyone, my name's Emma. I'm an F3 based in Bristol, and I'm going to talk about the results of the IBRA study. And as we said, the impact of radiotherapy on patient-reported outcomes of implant-based breast reconstruction. Next slide, please. So radiotherapy forms a really important part of breast cancer treatment, but it can cause problems following reconstruction after mastectomy. In the context of implant reconstruction, it's associated with things like capsular contracture and increased rates of implant loss, as well as skin changes and poor wound healing. What we don't understand so well is how that translates into a difference in patient-reported outcomes, so things like patient satisfaction and quality of life. And that's particularly true in the context of newer reconstructive techniques, many of which involve the use of mesh. Next slide, please. The IBRA study was a prospective cohort study that ran between 2014 and 2016 at 81 centres across the UK. It recruited consecutive women undergoing mastectomy followed by immediate implant reconstruction, some of whom went on to have radiotherapy and others who didn't. They were followed up over 18 months, and at 18 months, they were sent a questionnaire which included our patient-reported outcome measures. And for that, we used the BreastQ, which has been validated for use in this population. Over 1,600 women with cancer were recruited to IBRA, and 730 returned that questionnaire. Next slide, please. And these are the results that we saw, which have not come up very well. So each pair of bars that you can see is a different BreastQ domain, so a different aspect of well-being or quality of life. And the light blue bars are patients who didn't have radiotherapy, and the purple are patients who did. So you can see that across each of the 5 domains, patients who'd had radiotherapy reported worse outcomes than those who hadn't. We looked at this more carefully using regression modelling to adjust for confounders. And when we did this, we found that the difference between the groups was statistically significant in 3 of the 5 domains. You can't read them very easy because they're tiny, but those domains are satisfaction with breasts, satisfaction with outcome, and physical well-being. We also looked at whether the type of reconstruction that patients had had made any difference to this impact, and we didn't find any evidence that it did. So why is this important? Well, to our knowledge, this is the largest study to date to look at the impact of radiotherapy on patient-reported outcomes of implant reconstruction in these newer reconstructive techniques using mesh. So it provides really useful information that we can share with our patients when we're discussing their treatment options with them, as well as their reconstructive options. and it provides data that's relevant to patients about the type of reconstructions that they are likely to be having. It's also important because some of the proposed benefits of these neuroreconstructive techniques is that they may be less affected by radiotherapy. So the fact that this early data doesn't provide any evidence to support that highlights a really key area for future research. Thank you very much for listening. If you could go to the next slide, there's my contact details, and I'm happy to take any questions now.
Thank you for keeping to time. You timed it really well.
Spot on.
Well, thank you, Emma. That was a great presentation. I think the IBRA study is a great study that's been trainee-led, and I think it's a good hats off to the trainees for that. So my first question would be, how are you going to use this information in your discussions with patients? I think many of us who've been around for a long time know that radiotherapy affects the impact and the quality of our implant reconstructions. So how are you going to use this information?
So I think it's a tricky balance, isn't it? Because I would never want to suggest that patients should be put off having radiotherapy because of these results. But I do think it's really important to inform our discussions that we share this with patients. And the fact that we've got this data that includes the BreastQ, which is, specifically developed for use in this population and validated, gives us something that we can share with patients that maybe describes what they can expect from their surgery, what they can expect their physical well-being and their sexual well-being to be like following their surgery. So I think it's really important to be a part of the discussion around what they can expect the outcome of their reconstruction to be like. And also I think part of the consent process for radiotherapy, that it's likely to have that negative impact on their reconstruction.
Do you think we should be offering implant reconstruction to patients who we think are likely to get post-surgery radiotherapy?
I think as with anything, it's a balance of risk and benefits, and I think ultimately it's up to the patient, but at least with this data we have something we can use to inform that decision.
Okay.
I think we have run out of time, Emma. Thank you.
Thanks.
So that takes us to our next presenter, that is Fiona Wu. She's going to talk about, I think I've got preparing our patients for surgery, a feasibility project following the introduction of a prehabilitation program for breast cancer patients. Fiona, please come in.
Sorry. Good evening, everyone. Prehabilitation, or prehab for short, is a relatively new concept aimed at preparing patients for surgery. At Medway NHS Trust, we developed a prehab program for our breast cancer patients. Next slide, please. Our prehab program consisted of 4 main elements: prescribed and supervised exercise, educational nutrition, medical optimization, for example, referral to smoking or alcohol reduction services, and finally, psychological support. This preoperative intervention addresses perioperative risk factors, for example, smoking and obesity. The prevalence of these are higher in Medway compared to national figures. These same factors put patients at greater risk of post-operative complications. So we wanted to determine the effects and feasibility of introducing prehab as part of the breast cancer treatment pathway. Patients were referred from a single breast care unit and assigned to a control or intervention group according to patient preference. Next slide, please. Patients were asked to complete 3 questionnaires before and after surgery: the short form 12 survey, the hospital anxiety and depression scale, and finally the shoulder pain and disability index. So all 24 of our prehab patients agreed to participate in all their exercise sessions. On average, this was about 4 one-hour sessions spanning over 2 weeks. 2 patients were smokers at baseline and accepted referrals to smoking cessation services. We had 11 patients with a high BMI, and they received additional advice on healthy eating and weight management. 13 patients had raised HAD scores and were referred to counselling. The between group differences in the scores before surgery were not significant. The between group differences after surgery were not significant. but within group pre and post-surgery changes, anxiety scores were statistically lower after surgery amongst our prehab patients. Next slide. So prehab for our breast patients have shown positive changes. However, it's not as impactful as compared to other forms of major cancer resections, for example, colorectal. There was no change in inpatient hospital length of stay, readmissions, or complications requiring hospitalization. But prehab has empowered our patients to modify and adapt healthy lifestyle behaviours, which might provide a cost-saving benefit to the NHS in the long run. Prehab has a high rate of user acceptability. 93% of our patients rated our service as excellent and perceived the service beneficial as part of the cancer treatment and the recovery. So overall, we have shown that prehab can be integrated into the breast cancer treatment pathway, but further work is needed to improve uptake and to increase the study sample size. Thank you.
Welcome. You have done well. Stuck to time. Mark, you want to ask something?
I think this is quite a small study, and I think what might have been useful is to compare another group, because you compare to the patients who declined to attend, so they might be a specific subgroup. So I just wonder if you might have a better results if you compared it to a completely different group rather than those that were offered and declined. I believe there are 9 decliners compared to the 16 who did attend. How I mean, you've said it yourself, I think, already, but how practical do you think it is going to be to introduce these things on a mass scale? Because 25 patients has been offered to is a relatively small number, and in most big size units we're talking about 400 or 500 breast cancers a year. Would you, out of your group, select a certain subgroup of patients that might benefit more?
Yeah, looking at the results, it seems like the patients with the raised HAD scores, so the highest, who scored very highly in anxiety and depression, these seem to benefit more from having a psychologist touch base with them before surgery and after surgery, compared to, you know, the other elements of prehab, compared to like our colorectal patients, for example. So although exercise might not be a big factor when it comes to the breast patients, I think the psychological input plays a big part as part of their treatment.
Yeah, I think you're probably correct. I think psychology is quite a treasured resource. Not many spare psychologists in most of our services, so targeting might be the way forward.
Yeah.
Okay, thank you. I think we'll move on because we've got only 20 seconds left. Thanks, Fiona.
Okay.
So the next presenter is Alexos Dosis. You say, can we safely accept tumor at the inked margin in breast preservation surgery? Now this, you know, as we all know, is a very controversial topic, margins and tumor at ink. And it'll be interesting to see what Alexos tells us. Please go ahead, Alexos.
Hello, I'm one of the trainees from in Yorkshire Deanery, and I will be here presenting today the results of an audit that we conducted in margin policy after breast preservation therapy in our local unit. Next slide, please. As you're probably all aware, there is a big variation in margin policy after breast preservation therapy, not only in the UK, but worldwide. In our local unit, we follow the ABS advice of 1 millimeter free margin, but just to highlight, NICE recommends a 2 millimeter margin, and there's recently been a new practice evolving following the publication of the American Society of Surgical Oncology systematic review and meta-analysis in 2014. Which essentially most units now are beginning to adopt a no ink on tumor margin policy. Next slide, please. In view of this, we decided to review our own results and check essentially if it would be good for us to move into this a new policy. We conducted a retrospective review of all the patients that underwent a wide local excision or therapeutic mammoplasty over the last 5 years. Our database is a prospectively maintained one, and our primary endpoint was the rate of residual disease for those patients with close margins but no income tumor. We reviewed demographics, tumor characteristics, histology reports, and complication rates. We defined close margins as the one that was tumor was less than 1 millimeter away from the margin, but not in it. Next slide, please. So this table shows a summary of the results. Essentially, 188 patients had a re-excision following breast preservation therapy, and out of those, 58 patients had a close margin. Of those patients, 45%, which is 26 out of 58, had a residual disease in the histology report. I've just put a comment down there showing essentially that 50% was the result of the residual disease. It was 13 patients with DCIS and 13 patients with invasive disease. 11 out of those 26 patients had to have even further surgery after, again, another positive margin and residual disease. In view of all these results, we decided to adhere to our already local policy of 1 millimeter margin, and we will be awaiting essentially further research on the topic just to move on probably in the future on a non-tumoring policy. Thank you very much, and I will be taking questions now.
Thank you. You've stuck to time. Well done.
Okay. I think the question here comes down to, if you did a much bigger study and it showed nationally that when we re-excise for between 0 and 1 millimeter, we find further disease, is that a reason to stick with the policy we have for 1 millimeter? Or do you think that it's actually local recurrence rates that matter?
That is very difficult to answer, I think, because it might be essentially that most of these patients are going for radiotherapy anyway. So I guess it's probably what matters is the local recurrency rates, really, rather than just residual disease. But in Bradford, we have quite a special population of a lot of people with comorbidities. So we kind of accepted the fact that a 45% of residual disease at the moment wouldn't justify us moving on to a different policy.
No, I agree with you, because I think the reason we give radiotherapy is that it reduces, there must be cancer there, because that's why it reduces the recurrence. Otherwise, you'd only have to do wide excisions with clear margins. And I think the concern might be, and I think where your study, which backs up many others, is that in an environment where we're changing our techniques and sometimes omitting radiotherapy in certain groups that are deemed low risk, it might be more important to be attentive to margins in those populations than in all populations. But I say this is a debate that's raged the last 25 years. It's not going to go away anyway anytime quickly.
I agree, yes.
Can I just quickly ask Alexios what your pathologists were? Were they like strongly opinionated towards one or the other, or did they have a particular side to take?
Our histopathologists are not strongly opinionated, no. I think it was mostly the oncologists that had their preservations with regards to us moving to a different policy. They were more concerned about us essentially adopting a new policy.
Thank you very much. Thank you.
Thank you.
We'll move on to the next speaker, which is Lydia Jenkins. She's talking about how we can accurately and appropriately identify patients who can be spared axillary lymph node dissection following a positive sentinel node biopsy, and is the nomogram used in local UK population. This is a very topical subject, because as you know, in every meeting you go to, people want to do less and less axillary surgery now. So Lydia, please go ahead. Thank you.
Hi, good evening. My name is Lydia Jenkins. This is a project I did in Bradford while I was CT2. So it is, as the presenters have said, looking at how we can accurately and appropriately identify patients who can be spared auxiliary lymph node dissection after a positive sentinel lymph node biopsy. And we wanted to see if the MSKCC nomogram was of use in a local population. So in the era of de-escalation of auxiliary surgical treatment in breast cancer patients, we aim to see if the MSK-CC nomogram accurately predicted further lymph node positivity after a positive sentinel lymph node in our local population. If you could move on to the next slide, please. So we identified all patients who'd undergone a sentinel lymph node biopsy over a 7-year period, so between May 2011 and December 2018. This was from a prospectively maintained database. So using the MSK-CC nomogram, we calculated the probability of spread to additional lymph nodes in those with a positive sentinel lymph node biopsy who'd undergone subsequent auxiliary lymph node dissection. So as you all probably know, the MSK-CC nomogram is a prediction tool that helps the clinicians to assess the likelihood that a patient will have an additional positive node after a positive sentinel lymph node biopsy. If I could have the next slide, please. So from our patients, we identified 333 patients who had positive nodes at biopsy. So 123 of those only had ITC or micrometastases. 210 of our patients had macrometastases. Of these 210, 59 didn't have any further surgery. 151 patients went on to have further auxiliary lymph node dissection. Of those 151, 125 patients had an MSK-CC prediction score of greater than 10%. Of those 125, 57 patients, or 47%, had positive further nodes, and 68% or 53% of our population didn't have any further positive nodes. We then had a smaller group of patients who had an MSK-CC prediction score of less than 10%, so this gave us 26, and of those 26 patients, only 7 went on to have a further positive node, so that was 27% of the 26. It's also worth just noting here that we had a single auxiliary recurrence during this study period, and that was actually in a patient who refused to have an auxiliary lymph node dissection. If you could move on to the next slide, please. We have concluded that having an MSK-CC probability calculation of less than or equal to 10% can accurately identify those with no or low further tumour burden, and there is a minimal auxiliary recurrence in our population, despite a third of the patients not having any further surgery. So thanks very much, and happy to take any questions.
Can I just ask Lydia, please? This is a retrospective study over a few years, more than 5 years. That is one thing. And the second thing is, when you are doing this probability calculation, I can understand, how you worked it out, but there are lots of other confounding or soft factors around these sort of predictions. And do you think that if other things had been taken into account, such as in this, surgeons' preferences are also a big factor, do you think that might have changed the outcome of your study?
I think it definitely might have changed things. I think we wanted to see if there was a specific tool or score that we could use that would help to rationalize things, so we could explain it to patients in clinic and explain that there's a less than 10% chance of this happening with this prediction score. So I think it was more so we could use it to help consent patients in clinic about whether we should.
Any more questions? If there are no more questions, shall we move on to the next slide, next presenter? Thanks, Lydia. That is Emma Lumley, who is going to talk about MagSeed guide-wide local excision for impalpable breast cancer, an initial experience at a teaching hospital. Thanks, Lydia.
Good evening, everyone. Thank you for giving me the opportunity to speak. I'm going to talk to you about my unit's initial experience of using MagSeed. Next slide, please. The wire is widely recognised as the most conventional method of localisation. Inserted the same day as the procedure, the wire can lead to operating list delays. The wires protrude from the skin and can dislodge and migrate. The less widely used iodine seed has many benefits, but with intensely regulated measures that has led to its slow uptake. MagSeed is a new, simpler alternative. It is a small magnetic marker detected with a specialist probe that can be placed in the tumour up to 30 days prior to surgery. Placed in radiology, this technique provides more flexibility in scheduling, and once placed, is firmly implanted and does not protrude from the skin. Next slide, please. We performed 20 cases with MagSeed initially. It was a learning curve for our surgeons. 5 surgeons were trained up, with 4 cases per surgeon, all with the MagSeed representative present in theatre. Although not the same, MagSeed uses similar principles to the sentinel lymph node radioisotope probe with very transferable skills. We used unifocal cancers only, a single seed inserted per patient, with both ultrasound scan and stereo localization utilised. From the images shown, working along the top line first, you can see the probe in use. The surgeon marks the point over the highest signal with the probe, and the flaps are raised as normal. Repeat intraoperative checks can be performed with the probe at any point. The technology uses both distance from the seed and directional sensing to localize. You can now take out the tissue with the huge advantage of being able to cut and then check margins, no longer guided by feel alone. The MagSeed can be seen in the Faxitron, as seen bottom right, and sent off for histopathology with the specimen. The theory being better localization than wires, less tissue taken, and less cavity shaves required. Next slide, please. We encountered no device issues nor localization issues. 16 of the 20 seeds were inserted prior to the day of surgery with a median of 3 days. Of the 20 cases, we had 2 cases that had less than 1 millimeter radial margins that returned to theatre for further cavity shaves. Compared to the national stated wire positive margin averages of 17.2%, we feel 10% is very acceptable, particularly considering the learning curve involved. Verbal feedback from surgeons and radiologists has been positive. Our own data is too sparse currently to extract anything statistically meaningful, but we as a unit are planning to adopt a more widespread use of MagSeed. Thank you for listening.
Thank you, Emma. That was a very concise, good presentation. As you have said that this is just the beginning and you have had 20 cases and just sort of beginning to introduce it, what sort of response have you got from the wider NHS trust and support, with implementing this?
So our application process to have it as a trust has been approved, and we are going to roll out using it. Well, where I've moved from, so Leeds teaching hospitals are going to move to using MagSeed, and it's been accepted and approved. Although the costs are higher, I don't have exact figures on it. We've realised that it actually can help us with scheduling and patient numbers, and actually we're going to roll it out and use it. So it was a very positive experience for most.
Excellent, very good. Any more questions?
A quick one from me, Emma.
Yeah.
Surgeons, I haven't used MagSeed, but some surgeons have said that some more difficult cases are deeper ones where it's far more difficult to localize in big breasts. I suspect this is a very early series of the easier cases selected.
Definitely. They were all picked at MDC very specifically, non-fatty ptotic breasts. They were single cancers. They were large enough and they were picked very specifically to be simpler cases. We didn't do any bracketing or anything. So yes, our initial experience has been positive from both radiologists and surgeons, but we did use potentially the simplest set of cases. And I think going forward, we'll have to see how we do get on, because the signal is definitely less from the skin as opposed to when you obviously get right by the seed, as it uses a distance factor as well. And in a much larger breast, that potentially will provide an issue. So we'll have to take that forward. I don't think this is going to phase out wires totally, but I think it is definitely something that can be used in those simpler cancers, enable us to schedule our lists better.
Yeah, sensible approach, yeah.
Thanks, Emma.
Thank you very much.
So if there are no more questions, we can move on to the next presenter. That's Emma Howard. She's talking about day case parathyroidectomy, time to change the norm. Emma, please go ahead.
Thank you and good evening. My name is Emma Howard and I'll be presenting a single centre experience on day case parathyroidectomies. Over recent years, there's been a big drive across the UK to provide same-day discharge for surgical patients. And there's been a number of retrospective studies that suggest that same-day discharge for parathyroidectomy is safe. But the most recent Bates audit found that actually only 10% of all parathyroidectomies are carried out as day case procedures. And this is mainly because of concerns of bleeding, necessitating reoperation, and also concerns about post-operative hypocalcemia. Next slide, please. So our single centre developed a safe protocol to discharge patients the same day following both a total parathyroidectomy or a parathyroid lobectomy. Patients are discharged with calcium and vitamin D supplementation, and then their calcium levels are checked at day 6 or day 7 post-op, and they're seen in the outpatient department at 10 days, where supplementation is then usually stopped as long as they're normocalcemic. Next slide, please. We conducted a retrospective observational cohort study in a single unit, and most patients we primarily investigated the length of stay and 30-day mobilities of patients who had a parathyroidectomy over a 10-year period between the 1st of January 2010 and the end of 2019. Any patient who had renal failure or tertiary hyperparathyroidism were excluded at this point. Next slide, please. So a total of 300 parathyroid procedures were performed within our study period, 43 of which were excluded because they were renal patients, and 257 were treated for a presumed adenoma. 254 patients underwent preoperative imaging, which was usually a combination of ultrasound, CT scan, sesotimobi scan, and 252 patients histologically did have an adenoma removed. And interestingly, 240 or 93% of our patients were actually discharged the same day. Next slide, please. So of the patients who weren't discharged home the same day, 4 patients were planned admission for comorbidities, 2 had surgical concerns, one of which was a bleed from the suture line, which needed re-sewing in recovery, and one was because of a late operative finish. 2 patients were kept in for anaesthetic concerns, and 5 were admitted for social reasons. 3 patients actually didn't have a documented reason for an overnight stay, and 1 patient was a medical admission and a non-elective case. We also looked at the 30-day morbidity, and 10 patients in total had documented causes of morbidity. 1 patient did require IV calcium gluconate treatment for hypocalcemia, but 4 patients did have relative hypocalcemia who didn't need any additional treatment. There were 2 wound complications. 1 had a seroma which was aspirated and didn't need any further intervention, and a few patients had post-operative nausea or vomiting or palpitations which didn't have any underlying cause. So in conclusion, our single centre experience has developed a safe protocol which allows day-case parathyroidectomies to be our normal practice, and more than 90% of our patients are safely discharged home the same day with minimal risk of 30-day morbidity. Thank you very much.
Thanks, Emma. You just finished on time. I want to know what, lots of units implement day case discharge for various different reasons, and yours is thyroid in particular. But what was the sort of particular point in your pathway that you think allowed you to get these good results? Was there anything special that you implemented?
Some patients do have post-operative calcium checks immediately after surgery. So because the calcium levels do drop quite quickly, if they're done in the morning, they can have bloods done at sort of lunchtime and still be discharged home later that day. So it gives everybody everyone's a bit more happy that there's less of a risk of hypocalcemia because they've had a normal result and they're discharged home with supplements anyway.
I see a point. Yeah, that's a fair point. Any more questions?
From the survey, your service is an outlier service doing a lot of day case surgery. So what do you think are the main barriers to other units not adopting the same policy? Do you think it's facilities or do you think it's attitudes?
It could be facilities. I mean, one thing that probably helps in our centre is that it's a single surgeon service, so there isn't the differences in practice from that point of view, and therefore there's sort of a lot of experience in that area. And otherwise, I think it's just not having sort of the pathways in place. If there's a bit of if people are a little bit concerned about complications anyway and tend to hold on to people just until the next day, it probably is more attitudes then.
Thank you. Thanks, Emma.
Okay, so that concludes the section on short papers. So we're now going to move on to the talking posters. So what we've decided to do in this section is that each presenter will present for 3 minutes and then we'll ask some questions, because there's such a variety of topics that having a discussion at the end is probably not going to be very fruitful. So we'll do a very similar process that we have done for the last few short papers.
Yeah. So getting on with the posters, first we have Nadia Gulnaz, who is going to talk about evaluating radiological stroke ultrasound assessment of node-negative patients who underwent the sentinel lymph node biopsy. Nadia?
Good evening, everyone. So this was a study that we wanted to do because nowadays there are many studies like Sound, Insomnia, and BOG. They're actually looking into a more conservative approach to axillary lymph nodes, and they're looking into whether we can see patients more conservatively and treat them more conservatively. So the objective for this study was to evaluate accuracy of ultrasound in evaluation of positive nodal disease in breast cancer, and to assess the safety of ultrasound alone in breast cancer patients with clinically node-negative axilla. So this was a retrospective data of 96 consecutive patients who underwent sentinel node biopsy from October 2018 to October 2019. Using our electronic records, we collected the data and checked into their records. We took sentinel node histology as the gold standard and compared the ultrasound results with the sentinel node results. So a total of 96 patients were included, all of whom were female, and they had an age range between 31 and 83 years. Interestingly, 11 patients had a positive ultrasound report, but only 6 of these proved to be false positive based on the subsequent lymph node biopsy. 57 patients were found to be true negative, and 63 patients of all 96 were found to have negative sentinel lymph node biopsy. So in all, the sensitivity of ultrasound was 15.15%, which is quite low. But we found that the specificity for a negative disease was 90.48%, with a very fair amount of predictive value. So these graphs basically demonstrate the demographics, of the age demographics, and the other one on the graph number 2 on the right-hand side. It shows the red actually shows the results which were positive, and the blue shows the results of the ultrasound which were negative. Basically, in conclusions, our results demonstrate that ultrasound in comparison to sentinel lymph node biopsy is less sensitive in predicting positive axillary disease. Therefore, sentinel node biopsy still has to remain the mainstay in our setup. However, we all know that ultrasound is very operator dependent, and basically all these ultrasounds are performed by different people, and although in the same hospital setup, but therefore the results can vary, and there could be a limitation to our results. We've seen that there is a high specificity and
Nadia, I'll have to interrupt. If you can quickly wrap up, please.
Yeah, so yeah, basically I'm finished here. The mainstay of the conclusion is that we should still stick with a sentinel lymph node biopsy. I don't think we have better modalities for ultrasound at the moment to be sure that we can leave the patient with positive lymph nodes or clinically negative lymph nodes.
Thank you, Nadia. Any question? One question for Nadia?
So Nadia, what is your criteria for a positive node? Because there's no standard definition used in the UK for what an abnormal node on ultrasound is. There's no agreement between different breast units. So what is the criteria used in your unit for a positive ultrasound report?
So the criteria in our department is if they are larger than 1 centimeter, and if there is cortical thickening, then they take it as a positive one.
How much cortical thickening?
If they have more than 3 millimeter of cortical thickening, and if they are larger than centimeter, they will take those lymph nodes as positive ones, and most of them are biopsied or ultrasound guided.
Okay. I think what's one of the problems in this area is there isn't a standard definition amongst the radiologists, so we're comparing apples and pears in different units with their results.
Yeah, sure.
Thank you, Nadia. We'll move on to the next speaker, Rachel Smith. She's going to talk about can artisan fibrin sealant increase day case mastectomy rates. Rachel, please go ahead.
Okay, my name is Rachel Smith. I'm a general surgical registrar at Salisbury Hospital in Wiltshire, and I'm going to present our poster looking at whether a fibrin sealant such as Artis can increase day case mastectomy rates. So the British Association of Day Surgery recommends a day mastectomy rate of 30%. And one of the barriers to achieving this is the use of drains to prevent seroma formation. Patients are often admitted overnight to allow them to learn how to manage a drain, and also receive additional support from the breast care nurse team. Artise fibrin sealant helps delay clot breakdown and hence aids hemostasis, but it also has adhesive properties that reduce dead space and subsequent seroma formation. So in this study, we set out to evaluate Artise as an adjunct to hemostasis and a tool to reduce postoperative seroma as an alternative to inserting a drain. The study recorded patients from September 2015 to December 2017 undergoing mastectomy with or without an auxiliary procedure. All the patients were using Artise and it was all performed by a single surgeon. The main focus of our study was to record complications, but the number and frequency of seroma drainage was also recorded. So the graphs actually haven't projected very well on this slide, but moving on to the results. So firstly, I'd just like to apologise and make a small correction to the lowermost chart describing frequency of seroma drainage, which you probably can't even read. But the first bar should say 16 instead of 15, and the second bar should say 5 instead of 6. So 29 patients underwent mastectomy with or without auxiliary procedure. 4 of these also had a drain inserted in addition to Artise, and all of these patients were in the mastectomy and auxiliary node clearance group. There were no immediate complications recorded, and there was 6 early and 1 late complication recorded. 6 of these were postoperative wound infections, 1 of which required admission for IV antibiotics and abscess drainage, and the other was a recurrent blood-stained seroma that underwent exploration. Both patients that had a return to theatre and subsequent admission had drains inserted at their initial operation. So we concluded that using Artise, drains were able to be admitted in the majority of patients safely, and using Artise should allow an increase in day case mastectomy rates.
Thank you, Rachel. Can I just ask a quick question, if I may?
Yeah, sure.
You have mentioned no immediate complications or hematoma, but when you see them for your first post-operative visit, did you include that? Did you include that in your list of questions about potential skin rashes or delayed allergies or any other reactions?
Yeah, we did. We recorded any skin changes, any bruising at discharge, and then we followed it up with at day 7 and then 6 weeks post-operatively.
Okay, thank you. Any questions? Any more questions for Rachel?
Rachel, I'm interested in how you selected your patients. So were the 2 groups, who got Artise and who got a drain? Are they comparable groups? Are they the same size breasts?
Yeah, so the surgeon who that this data is from, she routinely uses Artise for all her cases and will standardly not use a drain unless she feels that she needs to put one in. So in this case, the 4 people that got drains in addition to Artise, one was anticoagulated for a metallic valve and had to be heparinized to bridge them back onto their warfarin. Yeah. 2 of them were high breast volume, so I think that was over 800 grams, and then 1 was extensive auxiliary disease.
But who were the 29 they were compared to?
Oh, this isn't. There's nothing that's being compared. This is just an observational study looking at 29 patients that had a mastectomy plus or minus an auxiliary procedure, all using Artise. The 4 patients that had drains were in the 29.
Oh, sorry, in your abstract it said this was compared to 29 patients, sorry.
Oh, no.
Okay, no problem.
Thanks, Rachel. The next speaker is Stacey Gillespie. Needs on what information do patients need after day case surgery?
Hi, good evening. My name is Stacey Gillespie, a trust grade doctor at Ipswich Hospital. So this project was carried out in our breast surgery department, where more than 85% of our patients have day case surgery. So we provided patients with a personalized post-op information leaflet, which included information about the operation, the operating surgeon, wound review, pain relief, follow-up appointments, as well as contact details for the breast care nurses. So within a month or so of their operation, patients are sent a patient satisfaction survey to evaluate the leaflet. So why did we do this study? Well, the project is based on the annual survey that is done by the National Cancer Patient Experience Survey, NCPES, which asks patients to rate aspects of the care that they've received. So despite all patients being told how their operation had gone, we found that only about 74% recalled that this information had been given in an understandable way. So from the papers that we've referenced, postoperative amnesia is a well-documented phenomena. At least 30% of patients are unable to recall verbal information given within the first 2 to 4 hours post-op. So from our little study, we had a 59% response rate. We found that 89% of our patients found the personalized leaflet to be beneficial and they appreciated receiving it. 94% felt that it provided a good explanation of their treatment and the post-op care. 91% felt that it was important that they know the name of the operating surgeon. And in addition to that, 55% of those patients, they made contact using the contact details provided in the leaflet. So by providing this individualized leaflet, it not only improves patients' understanding and recall of how their operation had gone, but their overall patient experience. So therefore, we concluded that most, if not all, day case surgical patients should receive a personalized written information leaflet regarding their operation and their post-operative care. Thank you for listening.
Thank you very much. Questions, please?
When you named the surgeon, did you name the fact that a trainee had done the surgery, whether or not they were assisted by a consultant?
So we would do that. So in terms of, so the leaflet here has a section where it says operation details and the name of the surgeon. So we would put the name, we wouldn't necessarily write it was done by a trainee, but we would put the name of the operating surgeon and the assistant as well, because we do have a duty of candor to our patients. So the leaflet is to provide simple information, but concise, that we think that our patients need.
Yeah, I sometimes, just to stress to everybody, I think that part of the consent process, you should be saying to the patient who's going to be doing the operation, and if it's going to be with the consultant or without, if it's not going to be the consultant whose name appears above the bed, as it were. Yeah.
Yeah.
Thank you. Thanks a lot. So the next, we have Maximilian Whitaker going to talk about single unit cohort analysis, which is a retrospective study comparing the efficacy of 1-day and 2-day protocols for technetium-99 radiotracer injection in sentinel node biopsy for breast cancer patients. I must say that this is a big problem in our unit because we do not have nuclear medicine on site. And we get lots of problems from, having injected the radiotracer day before. We do not have it on the same day. So it will be interesting to see what Max has to tell us. Max, please go ahead.
Hello, good evening. My name is Max Whitaker. I'm an F2 from Northwest London, and I'm representing the Charing Cross Breast Surgery Unit this evening. So we did a retrospective analysis looking at sentinel lymph node biopsy as part of 1-day or 2-day protocols. 1-day protocols being injection of the radiotracer the day of surgery, 2-day protocols being injection the day before the operation. And we looked at failure rate to pick up a hot node at biopsy. And our main objective was to assess whether failure rate to pick up a hot node is associated as being part of a 1 or a 2-day protocol. And we also had secondary objectives to look at whether the failure rate was associated with patients having prior surgery to the breast or concomitant failure of blue dye mapping at sentinel node biopsy. We looked at 229 cases of sentinel node biopsy in a 1-year period between September 2018 and 2019. And we collected data from operative notes from pre and post-operative MDT documents and from documentation from the nuclear medicine technicians at the time of the radiotracer injection. We found that there was almost equal split between these 229 cases between 1 and 2 day protocols, with 51% being performed as 2 day protocols and the remaining 49% as 1 day protocols. We found, in terms of our main objective, the failure rate in our 1 day protocol arm was 7.9%, and in the 2 day protocol arm was slightly higher at 12%. There was no statistical significant difference between these two values, but there is arguably a clinical significance to these values, given that in terms of raw data, there were about 6 excess patients in the 2 day protocol arm where there was no hot node found, and they would then have to go on to potentially for auxiliary sampling and auxiliary clearance, and the increased risk of complications associated with those like seroma and lymphedema. In terms of the secondary objectives we found that the failure rate was higher in patients with prior surgery to the breast at 21% compared to 9% in patients without, with borderline statistical significance, and with 55% in patients where blue dye mapping had failed compared to 6% where blue dye mapping was successful with strong statistical significance. So the chart there doesn't project again well, but there's a run through of the various different arms of the study. So in conclusion, while there's no statistical significant difference between the 1 day and the 2 day protocols that we found, there is arguably this clinical significance of the increased number of patients without hot nodes in the 2 day arm. And I'll take any questions.
Thank you, Max. Mark, any questions? This is an interesting topic.
Yeah, 2 things. I'm presuming you used a different dose of radioisotope for the 2 and 1 day protocols?
So the 2 day protocols did have an increased dose of the radioisotope compared to the 1 day protocols. I think that's an area as well for further research, because as far as I can tell, there's no guidelines as to how much it should be increased. And it's not something we looked at in the scope of this study in terms of the relative difference, but it's something that could be looked at.
I think most units have adopted the Almanac trial protocol, which was 40 megabecquerel the day before, 20 megabecquerel on the day. Another thing that has come from previous studies, which might be useful to look at if you haven't, is did you look at BMI?
No, so BMI wasn't one of the things that we looked at in this study.
Because again, the failure rate tends to be higher in patients with a higher BMI in previous studies. It might be, if you've got that data, it might be worth looking at that.
Sure.
From our for my interest, what is your standard? Do you use dual localization technique routinely? Some units don't.
So say again.
Do you use dual localization technique? Do you use both the blue dye and the radioisotope routinely, or?
Yes, routinely it is dual technique. Only in kind of exceptional cases would we only use single technique.
Okay, thank you very much. Thank you, Max.
No
We've got next speaker is Hamad Ahmed. He's talking about the devastating chest wall complications following a ruptured silicone breast implant. Hamad, please go ahead. Thank you.
Hello there, I'm Hanad Ahmed, a final year medical student at Southampton, and I'm presenting this case report concerning a ruptured silicone breast implant causing a chest wall silicone granuloma that resulted in chronic osteomyelitis of the ribs and sternum. So silicone breast implants have been used extensively in cosmetic and reconstructive surgery. Implant rupture is a known complication with incidences likely underestimated due to its asymptomatic nature. Upon rupture, silicone may spread beyond the implant capsule and reach the breast parenchyma, called an extracapsular rupture, which can lead to a foreign body inflammation leading to the formation of a silicone granuloma. Rare cases of silicone granuloma involved in the axilla, limbs, chest wall muscles, liver, lung, abdominal wall, and inguinal area have been described. However, to the best of our knowledge, we are the first to report a silicone granuloma causing osteomyelitis of the ribs and sternum. So the case was an 81-year-old female with a history of bilateral breast cancer who presented to our centre with a right-sided chest wall granuloma and chronic osteomyelitis unresponsive to antibiotic therapy. She was tender over the right sternal edge on examination, and she had a CRP of 182, but was otherwise well. She had a discharging sinus over the right sternal margin, shown in figure 1, and was booked for an anterior chest wall resection of ribs 2 to 6 in the sternal body, shown in figures 2 and 3. This was followed by reconstruction using a Marlix mesh reinforced with gentamicin cement and coverage with a myocutaneous pedicle flap, with the end result shown in figure 4. The patient recovered well and was seen in clinic 3 months later with good wound healing. And the takeaway points for me certainly were the potential severe complications that can arise from extracorporeal breast implant rupture, the importance of early diagnosis and the low threshold for imaging, and the importance of an early aggressive debridement approach of the affected area and utilization of a well-vascularized soft tissue covering to prevent prosthesis colonization and secondary sinus formation. Thank you very much.
Thank you, Mehmet. You finished well in time, so we can ask more questions, I'm sure. I'll ask a quick question. You know, the age of the patient, when you actually looked at this patient profile, did she have any other comorbidities pre-op that you think might have caused a more detrimental outcome? Of course, the age is there, but is there anything else that you saw in the patient that could have affected the whole outcome?
So aside from a history of bilateral breast cancer and hypertension as well, she didn't have any other comorbidities, so no diabetes, nothing else.
Okay, no diabetes or things like that. Okay, thank you. Mark, please.
Yes, I think obviously this is a very unusual complication, obviously very devastating for this patient, but it's something incredibly rare. Ruptured implants are incredibly common, and we as breast surgeons doing cancer surgery see some because our reconstructions become misshapen, etc. But there are probably hundreds of thousands, if not millions, of women walking around the world with silently ruptured cosmetic implants. And by the nature of the fact they're generally done in private practice with cost to surveillance, early imaging and finding these silent ruptures doesn't occur. And in lots of circumstances, nothing gets done about a silent rupture anyway if it hasn't caused a change of shape. So whilst I take the comment in your conclusion about being very aware of having low thresholds, I think as surgeons using implants, our concerns with implants are more related to things like ALCL, when seroma formation around implants, than they are trying to pick up silent ruptures, because what you're describing is devastating for this patient, but actually, you rarely, if ever, have seen this before.
Yeah.
Okay, thank you. So moving on to the next speaker, that is Varun Putnam. He's talking about the role of clinical judgment in offering adjuvant chemotherapy for breast cancer patients in conjunction with the Oncotype DX, which we are all aware of. And he is going to talk about a single breast unit experience. Varun, please go ahead.
Good evening, everyone. Hi, my name is Varun, one of the surgical registrars at Wiston. As we know, Oncotype DX is one of the most common tumor profiling tests that's been recommended by NICE. It basically predicts how likely a breast cancer is to recur after surgery and the likely benefit of having chemotherapy. So basically, NICE recommends Oncotype DX for patients who are ER or PR positive, HER2 negative, and lymph node negative patients. And this is basically for adjuvant chemotherapy. It basically predicts cancer recurrence and benefits based on a recurrence score. If the recurrence score is greater than 26, it means that they have significant chemotherapy benefit. The Oncotype DX is based on a RT-PCR test with the expression of 21 genes, which are 16 cancer genes and 5 are reference genes. So we aim to look if clinical judgment coerces in offering chemotherapy in these patients, in patients which in recurrence score less than 25. We aim to look at 40 patients over a period of 1 year who are eligible and were requested for Oncotype DX based on NICE guidelines. And these patients had the following criteria. They had the Nottingham prognostic index between 3.4 to 5.4. Most of the patients were G2 or a small number were G3 tumors. They were ER and or PR positive patients. They were HER2 negative and lymph node negative patients. So the median age of these patients were 58. equal number had, 20 patients had surgical mastectomy and the other had wide local excisions. The median tumor size was 25. One of the patients had a lymph node positive and he received the test. The recurrence score above 25 patients were around 9 and all of them received chemotherapy. 2 patients out of 31 who had recurrence score less than 25 did not receive received chemotherapy. And these 2 patients, one of the patient had a lymphovascular invasion and the other patient had pure mucinous carcinoma. And the MDT recommendation was to offer chemotherapy for these patients. In conclusion, in selected clinical scenarios, tumor profiling tests requests may be avoided where chemotherapy is definitely indicative and likely to offer benefit. This decreases financial burden. Oncotype DX roughly costs around £3,000, and obviously, not offering this will definitely not delay the opportune management. The decision to perform the surgery may be deferred until the histopathology result, MTD recommendation, clinical and patient factors are assessed, and it might guide for chemotherapy regardless of the Oncotype DX result. Thank you.
Thanks, Varun. Questions for Varun, please?
So Varun, can I just clarify when you are requested the Oncotype test? Because certainly in my MDT, we wouldn't request the test until it's discussed by oncologists and decided to be in a group where we're uncertain. So you request the test routinely earlier in the pathway?
Yes, we do. It's based on the MDT recommendations, basically. Once MDT decides that maybe this patient needs to have an Oncotype DX, then we do usually.
Okay, but I'm trying to get, how would you then change that system? Because if you've already said we're going to give chemotherapy, there's no point having a test. If you're going to recommend it or not recommend it. So surely this is still just the ones that are in the indecisive group in the middle where you don't know.
So few patients who had certain factors, like one of the patient had a lymphovascular invasion, and this patient definitely chemotherapy will offer a benefit. And one of the patient had a pure mucinous carcinoma. I predict that it might be a micropapillary pattern, which have got a very bad prognosis. So in these 2 patients, chemotherapy would offer benefit. So irrespective of what the Oncotype DX suggests, offering chemotherapy in these patients would have added benefit for the patient. So in these selected groups, maybe we can, defer it.
So what you're saying is your MDT in those 2 cases actually recommended chemo, but still ordered the test?
Yes, please. Yeah.
I've got you now.
If not ordered the test, yeah.
Yeah. Okay.
Thank you, Varun. Thank you very much. And we have Mr. Shalabi has not been able to join us, so we move on to Michael Hanna, who is going to talk about the incidence of thyroid cancer in patients with a FNA of THY3A and 3F.
Good evening.
Michael Hanna. Michael, please go ahead.
Good evening. I'm Michael Hanna. I'm a surgical registrar in the Whittingham Hospital in London. But we designed this study when I was in the endocrine surgery department in Nottingham to look at the incidence of thyroid cancer in patients presenting with thyroid nodule and fine needle aspiration of TY3A and F. As you know, many people walk around with thyroid nodule they don't know about, but when they come to the clinic and have an ultrasound scan and cytology, some of the results are really straightforward, like TY5, which is cancer, and TY2 is benign. But the TY3 is usually a big question mark and forms a diagnostic challenge, and usually a hemithyroidectomy is warranted to get further diagnosis plus or minus cure. So the objective of this study is we wanted to look at how many patients with TY3, A and F had actually cancer from 2016 to 2019 in the endocrine surgery department. And also, we looked at how many patients required completion thyroidectomy and radioactive iodine. So we have an idea what we need to tell the patients in the clinic based on our local results as well. So we found that 40 patients had TY3, 9 with TY3A, and 31 with TY3F. The mean age was 49, and most of them were females, around, not very clear, but we had around 88%, 93% were females, and also most of them came following hemithyroidectomy. Interestingly, quarter of the patients had cancer, and the incidence of the cancer in the TY3F was a little bit higher than TY3A, p-value of 0.4 giving the sample size, but that was compliant with the literature. Furthermore, 17% required completion thyroidectomy and 20% needed radioactive iodine. When we got the histopathology, around 5, in terms of grading, around 5 patients had T2, 2 patients had more advanced cancer of T3, and 3 patients had earlier cancer. In a nutshell, the incidence of a thyroid cancer in TY3 is actually low, but it's negligible. And the TY3F carries higher risk than TY3A. And 1/5 of the patients actually who had cancer required completion thyroidectomy and or radioactive iodine, and those things need to be discussed with the patients in the clinic. Thank you. Questions?
Thanks, Mike. So questions, please, for Mike.
So how do you go about counselling patients using these results? What's different with how does this change your practice? Well, yeah. So for instance, when the COVID came, people with TY3, some surgeons they advocated that we can actually give them like 6 months with another ultrasound scan and additional fine needle aspiration, since it's 75% will be benign. But in our local practice, we actually advocated that if it is TY3F, we advise the patient should undergo hemithyroidectomy, diagnostic one, because it carries higher risk of cancer. So we carried out that even during the COVID era. Okay, very good. Yeah, thank you. Any more questions?
I don't think there are any more questions so far, but I think this is our list for the free paper series.
Okay, so there's one question that's come through, which I'm hoping that Vicky can answer, is where can we see the e-posters? There we go. That's very helpful.
Yeah.
So we're one speaker short and I've got a little bit of time, and I'm just wondering the best way to use that time. So maybe if all the speakers want to unmute themselves, and we'll have maybe discuss 1 or 2 themes from the evening, because I say it's a wide variety, predominantly breast with a little bit of parathyroid and thyroid thrown in. For us all to talk about. I mean, one of the themes I thought was day case surgery, and day case surgery rates, and people being willing to do day case surgery in parathyroid, and day case surgery rates with drain usage. So in your units, how many of the units, or people speak up, have a drain discharge policy where district nurses are able to look after drains to facilitate day case discharge? I mean, Derby and Burton, we have a system where basically women are discharged as day cases with or without drains, so it makes no difference to our day case rate whether we need a drain or not. And it's normally other things that are factors with day case discharge. Is that the same case in those units?
We have the facility to send us home in Leeds with a drain. Again, if the clearances are staying, it's often for other reasons as opposed to because the drain's in situ.
Yeah, ours is very multifactorial. Obviously, the drain is one aspect, but I think a lot of our breast lists are all in the afternoon, and we've got quite an elderly population in Wiltshire. And then I think some of it is a little bit of a culture change that needs to happen within like our day surgery, which I think is happening, but it's a work in progress.
I think you'll find that if you look at the history of surgery, it is a culture thing. I'm very old compared to youngsters. When I was a houseman, hernias stayed in for a week. You know, when I started as a consultant, my wide locals and then auxiliary node samples stayed in for 4 days with a drain. And the biggest obstructors to change were actually the patient support group who were saying, well, that didn't happen when I had my breast cancer treated.
Yeah.
And the new patients don't know any difference. If you put a safe system like the one we've heard described earlier, where people have actually looked into it and put in safe procedures and clear communication. So we've heard about the leaflet and information tonight. We've heard about, you know, drains or sealants, whichever you like. We've heard about changes in parathyroidectomy sort of practice. That's all down to usually enthusiasts driving it with a safe pathway. And it's often having a nurse specialist to oversee something to get it going, or having a contact number to be able to ring into out of hours, or having a means to go to district nurses to talk to them, asking about, you know, removing drains in the community and having a training program with the breast care nurses. But I say, what about COVID? Has that affected people's ability to do day case surgery? Because obviously it's ideal to do it, but often the community closed down, as in the ability to take drains out.
I think people's patient attitude towards not being in hospital has improved with COVID, because they're worried about what they're going to catch. So yeah. I think they're more accepting of going home, even if it means a bit more effort on their part, which is probably going to be a positive.
I think in our unit also similarly, COVID has a positive impact on day surgery, because patients are saying, please, can I go home? You know, even if they have the slightest chance, or they don't want to catch things in the hospital. And I think one factor that we have found is our anesthetists are very actively involved in day case surgery with the pain management. And I think that's a big factor, that the type of anesthesia they give and the TIVAs and other things, so which actually it's helping us a lot to mastectomies as day case.
That's a very good point, because your anaesthetist is absolutely key. And if you keep getting given the breast surgery is easy from an anesthetic point of view, and it's a good way to learn for the trainees, and all your patients are going home feeling nauseous or in pain, high quality day case anesthesia is very important. I agree with that. Okay. Ghazala, anything else you want to bring up? Any other themes?
No, I think we had a very nice, lots of mixture of things, and it is very heartening to see that people are still writing in the middle of COVID. You guys have done a lot of work. It's a lot of effort, because it can be quite hard to actually carry out your clinical duties and then even write, academic work is not easy. It is something that we should all appreciate.
Is there anything else anybody else would like to bring up or discuss? Okay, if that's the case, well, thank you all for participating. It was an enjoyable session. Lots of hard work had gone into behind to present these things. I know that. So well done to you all, and enjoy the rest of the evening. Okay.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.